Welcome, everyone, and thank you for joining us today for the second inHEART webinar of 2026, entitled CNA Revisited, Imaging, EGM Guidance, and GP Targeting Strategies. We had over 165 attendees register for today's event. We are joined by Dr. Josselin Duchateau, electrophysiologist at the Bordeaux University Hospital, and Dr. Tolga Aksu, professor of cardiology at AIU Medical Park Florya Hospital in Istanbul. In addition, we are joined today by guest panelists Dr. Mouhannad Sadek, electrophysiologist, Southlake Hospital in Toronto, and we will be joined by Dr. Juan Zerpa, director of the Cardiosync Arrhythmia Center at the Hospital de Coracao in Sao Paulo. My name is Kristen Lomas, and I'll be facilitating today's conversation along with my colleague Isabella Portavecchio. We are recording today's discussion for use online and to share with clinicians, so your continued attendance on this call will serve as consent to the audio and video recording and its distribution. Our format for today will include two presentations followed by Q&A. Attendees, we encourage you to submit questions via the Q&A feature at the bottom of the screen, and we will work your questions into the conversation. We have a lot of content to cover, so let's go ahead and get started. Dr. Duchateau, we will start with your presentation.
So, hello everyone. Yeah, I'm going to share my screen. Hold on. And this should work. Okay. Can everybody see my screen? Yeah, seems okay. So, I'm going to focus on our current strategy in Bordeaux for cardioneuroablation, focusing on what we do, but also what might seem a little bit different from what is usually described in the literature, focusing on these differences. I think that's what makes the most sense. So just as an introduction, I'll be focusing on this patient, which is a 31-year-old male who is a sailor. So this is an important first piece of information, because it means that because of his job, him having syncope is a real issue in his daily life. He has had multiple recurrent syncopal episodes with very short prodromes. Short prodromes, again, makes syncope, in this case, a real serious issue because he can get hurt and potentially fall off his ship. And he's had a mixed response at head-up tilt table testing with only a short pause of 5 seconds. So actually, this sort of clinical profile led us to implant an ILR, which is what we do in standard practice in Bordeaux when we feel there's a potential for invasive therapy. We always have the reflex to document a spontaneous episode of syncope using an ILR. And that's because of this figure here. So this is an old publication in 2006, but it's been confirmed by several other authors. And it shows that when you have a patient who actually has either a pause on the tilt test or no pause on the tilt test, when you implant an ILR and you look at his spontaneous recurrences, there's often a mismatch between the phenotype you can record on the heads-up tilt table testing and the spontaneous phenotype that the patient has. And actually, I'll even push this a little bit further. There's a study by Brignoli that shows that patients with a negative tilt table test are the ones that respond the best to pacemaker therapy down the road when they have spontaneous episodes of asystole on the ILR. So really what this means is that when you have a patient and you're asking yourself whether or not he's a good candidate for cardioneuroablation, start by putting in an ILR. It helps for the diagnosis and it will help for follow-up. So then how do we do cardioneuroablation? So just as a reminder, cardioneuroablation focuses on targeting the GPs. GPs are structures that contain neurons that innervate downstream both the sinoatrial node and the AV node. And these are the neurons that we're targeting. Like anything that goes into the heart, these neurons and the nerves that innervate these neurons go through the cardiac hilum, which is the region of the heart that's attached to the mediastinum, so to the rest of the body. On this cardiac hilum, the posterior cardiac hilum, you can see the pulmonary veins here. You can see the vena cava, of course, and you see in green the outline of where the pericardial reflections are. So this is the limit of where everything that goes into the heart comes through. Around this cardiac hilum, you have fatty structures, fat pads, that actually contain the vast majority of the neurons that we're targeting. So they've been given a specific nomenclature that actually several naming conventions. I'll use the historic naming convention that was used by Armour, and he describes these different structures as left superior, right posterior, left posterior lateral, and left posterior medial GPs. And actually, in his histological study, he showed that the proportion of neurons was very different, very variable from one region to the next. And actually, you can see that most of the neurons are located in two main regions, the right posterior GP here and their left posterior medial GP here. So remember, these two regions are the regions that contain the most neurons. There's also some specificity in the downstream innervation of these regions, meaning that the neurons that are located in the right posterior GP here are mostly targeted towards the sinoatrial node, okay? And the neurons that are present in the left posterior medial GP here are mostly targeting downstream the AV nodes. So if you're, for example, aiming for selective atrioventricular node denervation, this is going to be your primary target. And if you want selective sinus node denervation, this is going to be your primary target. Great. So the conventional approach and the first approach that was described to target these regions was actually to use signals that you record endocardially to try and identify the GPs. The problem with this approach is that it really relies on a very weak rationale, which is that the concept that potentially the presence of neurons and nerve fibers within myocardium would disrupt the myocardial architecture and would create fragmented potentials. This actually is pretty much just a concept and hasn't really been formally proved from a histological standpoint. So there's a very weak rationale for doing this. In contrast, we know that these fat pads histologically are really located in the fat pads, and fat is something we can see on the CT very easily. It has a very distinct signature. It has a low intensity between minus 150 and minus 50 Hounsfield units usually. So you can really detect it on the CT. And these fat pads are what you see here. So I talked about fat, which is what you're seeing here in yellow, but we're not going to target all the fat around the heart. We need to target fat pads. So what is a fat pad? A fat pad is just a collection of fat, but that has a sort of spherical symmetry. So the way to extract this spherical symmetry signature is to do specific erosion. When you do an erosion of this fat, you start by removing the outer layers of fat. And when you have something that's just a sheet of fat, it will be eroded very rapidly and it'll just vanish with serial erosions. However, when this fat is shaped into a ball, then it will persist after several erosions. This is what you're seeing now. So right now, I'm performing serial erosions of the image, and you can see that very early on, most of the fat vanished, and you're keeping specific regions that persist after several erosions. And when you accumulate all of these images together, you get these hot spots here at the left posterior medial GP here and at the right posterior GP here. So this is what we're targeting in Bordeaux. We're anatomically aiming for these regions. And there's a clear advantage over the theoretical concept that this is a right target compared to signal-based ablation, which is that the area that you're going to be targeting is really much smaller than the area of fragmented signals when you map. And this is a study that we did last year that compared these different regions, the size of the different regions of these two techniques. So this is our current workflow. We start by first recreating the anatomy of the left and of the right atrium. This allows us then to efficiently merge the anatomy that we're creating with our mapping system with the pre-procedural CT scan. So getting both atrias, the left atria, which you just saw on the right atrium, and then merging this anatomy with the CT scan. So here you're seeing the merge. We just align the right atrium, of course, and then align the left atrium as well. And when these two structures are very well merged, then you can start and target structures that you can't record using electrograms directly. Okay? We always take care also to avoid complications. These are young patients, so your number one goal, beyond even the fact that you want to treat these patients, is to avoid any source of complication. So the structure that you're seeing in green that was segmented from the CT scan is the right phrenic nerve. So this is a structure that is often quite close to the right posterior GP that you have here. So you see that we're confirming the position of the right phrenic nerve and confirming that we have sufficient margin from this right phrenic nerve to ablate this right posterior GP. And the way that we assess the acute efficiency of our ablation is by transjugular vagal stimulation. I think that it's very important to have clear targets, so the anatomical targets are have a very clear endpoint. And transjugular vagal stimulation provides you just that. So at baseline, in any patient, when you do an efficient transjugular stimulation, you get an asystolic pause. As long as he has a well-functioning autonomic nervous system, every time you stimulate his right internal jugular, he'll have both a sinus pause and an AV node block. This is what you're seeing here. We're pacing the atrium while we're doing the right jugular stimulation. So both sinus node dysfunction and AV block induced by stimulation. The other thing you have to take care of, the other complication you have to avoid is this one. So the artery that you're seeing here is the sinus node artery. It was reconstructed from the CT scan as well. And you can see that it's going through the superior right GP here that is sometimes targeted by other teams, and that we also target as a secondary structure when we fail to completely denervate the sinus node using the right posterior GP only. But you can see that the sinus node artery goes through this region. If you occlude the sinus node artery, then you can get structural damage to your sinus node and structural sinus node dysfunction that no ablation will cure down the road. And when you look at the reports of sinus node dysfunction after cardioneuroablation, and unfortunately there are some, they all point to this same structure. And all of the patients that had this complication in all of the published case reports were actually ablated in the area of the right superior GP. So this is really an area you should avoid as first intention. Okay, so then when we ablate, we look for acute denervation endpoints. What you can see acutely is just sinus rate acceleration. Okay, so what you're seeing here, going from a sinus rate of about 50 beats per minute to over 70 beats per minute here after a single application. And then, of course, we extend this ablation to ablate the entire GP from the right side and often from the left side as well. And once we've ablated, we verify that we get complete response through vagal stimulation. Okay, so this is right side vagal stimulation. You can see that after our applications, we no longer get sinus node dysfunction and we no longer get AV block. Are we finished or are we not finished? We are actually not finished, because the other thing you have to keep in mind is that for this procedure to be efficient, but not only acutely, but on the long term, you really need to target the GPs themselves, not the axons that are leading to these GPs, because the axons are going to grow back potentially, but the GPs won't, the neurons themselves won't. And when we ablate the right posterior GP, we're not only targeting the neurons that are located in this GP, but we're also damaging axons that come down and go through the posterior aspect of the interatrial septum here. And these axons are going to innervate downstream the left posterior medial GP. So by ablating at the right posterior GP, we're damaging these axons, but this damage is reversible. So the way to test for AV block, for potential residual AV block, is to stimulate the left vagal nerve. So going into the left internal jugular. And this is what we did. And when you do that, you see that you don't get any sinus node dysfunction, but you do get your residual AV block, which was expected. Okay? So then, once again, we acutely denervate the AV node. So we're going to target the left posterior medial GP. And the acute endpoint is different. We can't see the change in the heart rate, but what you can see is this change in the PR interval. So what we usually do to make this more obvious is that we pace just before Venkaback point so that we get a clear long PR interval and also something that you probably just saw, which is respiratory fluctuation in the PR. You can see that the PR is sort of oscillating around its value here. This is due to a respiratory effect, and these respiratory effects are vagally mediated. So actually, the first indicator that you've denervated the AV node is that you lose this fluctuation in PR interval. So to ablate this left posterior medial GP, there's nothing specific to do. You have to identify the best access site. It could be from the right atrium. It could be from the left atrium. In this case, in this particular case, you can see that the GP itself is more on the left atrial side. So we're going to target it from the left atrium primarily. And one thing you have to consider, and you always have to be very careful about, is that there's often the esophagus just behind this structure. So it's a very good practice. Sorry for the noise. Hold on, just turning this off. Okay, it's very good practice to monitor the temp in the esophagus because you could get potential damage. And actually, this temperature probe in the esophagus is also a good indicator of whether or not you're ablating on fat. Because when you're ablating on fat, you get a very slow kinetic, you get potential warming, but after really a long time. When you're ablating outside of fat, so you're actually not on the GP itself, then you get a very rapid, very sharp increase in temperature on your probe. So it's also an indirect indicator of whether or not you're targeting the right region. So when we ablate, we check that we get PR shortening. This is important. It's important not to get PR lengthening during ablation, even though here we're quite far off from the compact AV node, which is a structure we don't want to damage. You can see on the figure here that we get PR shortening during ablation. This is what we want. And once we've done that, once we've ablated this region and covered the entire GP, we check using transjugular stimulation again. So you can see that transjugular stimulation is very important because we did have PR shortening, but you can see through the stimulation that our effect was incomplete. We went from complete AV block to 2-to-1 AV block, but still, we need to do more ablation to make sure that this patient doesn't come back. So this is what we did. We complete our ablation with additional lesions on the left side and additional lesions on the right side. And once we've done that, we check again. And this time, our response to stimulation is complete. Okay? So just to conclude, CNA targets the GPs, mostly located in the pericardiac fat pads. CT is a great tool to locate these fat pads and really facilitate ablation, make it much more objective, and help you target the right regions and restrict your ablation and focus on the right regions. I think it's very important to keep transjugular vagal stimulation because it's really the best tool to assess acute efficiency. There's clear right-left selectivity in the innervation of the sinoatrial node and the AV node, and you should always keep that in mind and always do stimulation from both the right side and the left side to make sure you fully denervate both nodes. Special care should be given to avoid complication, sinus node artery damage, phrenic nerve palsy, and esophageal lesions. And CT really helps you, at least for the first two, in a very significant manner because it allows you to visualize these regions. Thank you very much.
Well, Josselin, that was a great presentation of a nice case of a difficult scenario that is the AV node block. And this is why the utility of merging the CT integration helps you to find where these fat pads are located and trying to direct your ablation through these fat pads. But the issue is that we as you well explained, we try to ablate these connections through the ganglia. We cannot pretend to ablate the ganglia that is really epicardial. This is
Yeah.
a really, really nice stuff. The issue that you can visualize the esophagus on this point is also important because you can see it with the temperature probe, but also find it in the tomography.
Yeah, clearly. You saw how close it was from the left posterior GP. I think it's very instructive, especially when you're ablating from the right side, since this is not a region that we're ablating routinely when we do AF cases, for example. You might not expect to be close to the esophagus, but in fact, if you're just a little bit too low, you're directly in the IVC, so in the inferior vena cava, and you're potentially directly in contact with the esophagus, and you should be really careful about that.
Can I ask you a quick question? Or maybe two quick questions. What are your ablation settings? Because for AFib we tend to do high power short duration, and I don't know if that's enough. So I want to know what you do. And the second question is, you tend to I notice you tend to shave off the fat and target really the dense portion of the fatty region. Roughly, how many ablation lesions do you do per GP, in your experience? And I noticed you really target the dense area mostly.
Yeah. So for power settings, so I tend to do a little bit of high power, high duration, So I mean, we need to go deep inside the fat. So we don't want to have steam pops. So it means we need to keep a superficial temperature that is reasonable. So I rarely go beyond 35 watts, almost never. I usually don't go beyond 35 watts, but I do very long burns because we know, that the electrical conductivity is very low in fat. The ratio is about 20 to 1 compared to healthy myocardium. So in terms of thermal conductivity, so diffusive effects, it's also bad in fat, but not as bad. The ratio is about 3 to 1. So if you want to go deep in fat, your best bet is to do maybe a little bit lower power so you don't get the steam pops, but you really need to do those long lesions. And actually, you really see that very clearly in the acute response in these patients because they have this very progressive PR shortening. Even after 20, 30 seconds of burns, it's still going down in terms of PR or up in terms of heart rate, depending, of course. And it's still improving with your lesion. And what Juan said is very important. I think the AV block cases are probably the most challenging because sometimes the access you have to that posterior GP is difficult. It can be from the left side, from the right side. You need sometimes from the posterior CS, you need to really triangulate. And what the CT scan gives you is also a a strong argument to say that you're pointing in the right direction. So it helps you focus on the right regions and put a lot of energy in there because you need to put a lot of energy to burn through several millimeters of fat.
So how long?
Also,
Yeah.
30, 45,
yeah,
60?
that's the other one. How
Yeah.
long do
So,
you get
so
it?
at least you saw.
And an additional comment, Jocelyn, just to would you consider high power in this situation? Because high power we expect to have shallow lesions.
Yeah, I think what counts the most is the duration, of course. So I do at least 1 minute, sometimes more in different patients. At least 1 minute, I can go up to 3 minutes. There are several studies on the VT side that show that, after 3 minutes, it tends to plateau. So you're not going much more deeper. Anyway, you can go up to 5 minutes if you want, but I think it doesn't make a lot of sense to do a lot more. Then you waste a lot of time. And yeah, I forgot to answer the question about the high power part. Of course, you shouldn't do high power short duration. That's the opposite of what you should do. You should do long burns. And my main argument was really a time argument. But if you're doing 1 minute of burn at 35 watts, you're also going deeper than 1 minute of burn at 30 watts, for example. Of course.
That's amazing. And I think that's a very important point for people who are going to start pursuing this procedure.
Oh,
right?
Josselin,
And
just another question. Just quick comment about how about starting to simulate the left jugular vein, the left vagus. Because you start with the right, and then you see that you achieve this AV node denervation, then you move to the left.
Yeah.
Maybe this can short a little bit the time.
Yeah, sure. So this case, we have a protocol right now where we randomize the order of the ablation. It's try to really understand how things are connected, how which vagus nerve is connected to which GP. So right now, what we tend to do is start by stimulation from the left side and ablating the AV node region first, and denervating the AV node before we actually target the sinus node. And this is very instructive because it shows us that you can most of the time achieve full AV node denervation just by targeting the left posterior medial GP. So it's really interesting to see. And then we target the sinus node as a secondary step. Yeah.
An important issue as well is like going for bilateral approach, and how do you going to start on the lower GPs and then you go higher. But maybe sometimes we have seen this. You achieve partial denervation, even going to the posterior medial GP, left and right. Then you have
Yeah.
to move a little bit up, getting up to the septum just to achieve better vagal AV node denervation.
Yeah, that's true. I mean, it's also very hard to generalize. So I think that the the majority of cases are okay when you do sinus node denervation from the posterior GP, right posterior GP, and then AV node denervation from the left posterior medial GP. So the two regions that we saw. But in fact, that's like maybe 50% of patients, and then you have those patients where you have to extend the right side ablation a little bit more and it denervates the AV node. You also have patients where you have to ablate the right superior GP or else you never get to complete denervation. You have exceptional patients, in my opinion, it's exceptional in my experience, where you have to ablate the left superior GP. But yeah, it's the majority of cases, I'd say it's a good way to start right posterior and left posterior medial. And I think it's also a very strong point for transjugular vagal stimulation, because then you know how to stop when you know when to stop, and you can really restrict your ablation to just what's necessary.
Awesome, excellent. We're gonna see another great presentation. Chris, can we move on?
Hi everyone.
Now we're gonna have my good friend Dr. Tolga Aksu, the master of the CNA, now seeing what we have with CT integration. Go on, my friends.
Thank you so much, Juan. Actually, in this presentation, I will try to discuss our expectation about this issue, because we recently compared EGM guided CNA and then CT guided strategy to see acute and short-term follow-up data. But actually, Josselin perfectly explained the anatomy, but in his presentation, he said that we should target real epicardial autonomic ganglia, and if we just ablate axonal fibers, our lesion will be transient due to axonal regeneration process. Let's see some anatomical data about that. As you see in here, real autonomic ganglia or neural body of parasympathetic system located in epicardial area. But we are trying to do endocardial ablation during CNA procedure. So our lesion will firstly affect this myocardial or even endocardial axonal fibers. So during the CNA, we are trying to do some permanent effect for this epicardial ganglia site. But please remember, there are at least 1,500 autonomic ganglia around left and right atrium, but in 3 epicardial fat pad. This is a real anatomical schematization from one of our study with Professor Danius Paulo from Lithuania. We tried to show you the localization of the great majority of epicardial ganglia located in these 3 epicardial fat pad. The first one is aorta superior vena cava fat pad. The other one is right pulmonary vein and right atrial fat pad. This is the biggest one and mostly important for vagal innervation of sinoatrial node. You are seeing the very close relationship between this epicardial fat pad and sinoatrial node is here. And finally, inferior vena cava, left atrial fat pad, and it's very close localization of AV node. So, in the concept of armor, they define 5 major and 2 minor GP. And if we compare the localization of this anatomical schematization and our 3D mapping data, you are seeing the localization of right superior GP, right inferior GP, left inferior GP, posterior medial left GP, and finally Marshall tract GP in 3D mapping system. But again, this figure drawn by Professor Pauza based on real anatomical data to explain the inclusion of post-ganglionated fibers from the GP side to the target organ. For example, if we remember the possible localization of sinoatrial node in here, we see that the great majority of parasympathetic innervation is provided via right superior GP. But please remember that if you ablate this post-ganglionated fibers via superior vena cava, you can also eliminate parasympathetic innervation of sinus node acutely. So you can see an increase on sinus rate acutely, or you can eliminate extracardiac vagal stimulation acutely. But of course, we should target real epicardial ganglia for permanent damage. And this is a very important point. We are seeing the possible localization of AV node in here, but please look at that. Mainly, posterior medial left GP or inferior vena cava left atrial fat pad provides vagal innervation to AV node. But look at that, Marshall tract, right superior, or even left superior GP sometimes provide vagal innervation to AV node. This is why to eliminate AV nodal parasympathetic innervation is more difficult than sinus pause or classical sinus bradycardia cases. So there are still some unresolved steps in CNA. We know that, for example, some groups use high frequency stimulation. There are too many limitations of high frequency stimulation. We use fragmented EGM, but we also know that if there is any fibrosis on left atrium, we can see some irrelevant fragmentation, or near field or far field electrogram can cause fragmentation on electrogram. So CT seems reliable anatomical landmark to see the localization of these 3 epicardial fat pad and to detect the great majority of autonomic ganglia. So why inferior vena cava left pad and right pulmonary and right atrial fat pad is important? We can understand by using this physiological experiment from animals. In this well-designed study, Billman and Randall et al. Checked right atrial and right ventricular electrogram during baseline, during vagal stimulation, and during vagal stimulation plus atrial pacing. As you know that vagal stimulation should cause negative dronotropic and negative chronotropic effect. So we should see right atrial bradycardia and right ventricular bradycardia, but during right atrial pacing, there is still right ventricular bradycardia due to high degree AV block. This is a normal response. But what if we surgically remove inferior vena cava left atrial fat pad or posterior medial left GP area? Look at that. During vagal stimulation, there is still right atrial bradycardia, but during atrial pacing, we don't see any right ventricular bradycardia. So we eliminated parasympathetic innervation of AV node by extracting this area. And then they removed right atrial and right pulmonary fat pad, of course, surgically, and there was no right atrial and right ventricular bradycardia anymore. So this area should be important for vagal innervation of sinoatrial node. But of course, in human, it's a little bit more complicated. In fractionated EGM guided arm, we actually used our well-known technique. We checked the number of electrogram in each area in left and right atrium. If we see more than 3 deflections on electrogram, visually, we tagged this area, and then we try to ablate all this electrogram. And of course, if we see any vagal response in any EGM area, we keep on the ablation and we try to completely eliminate this vagal response as well. These two ones are ablation endpoint. But again, there are too many limitations of fragmentation as well. So In the other arm, we try to check combination of contrast enhanced CT by using segmentation of epicardial fat pad, and of course we try to check which epicardial fat pad thickness is better to see the localization of this real autonomic ganglia site. And then you see the different cutoff for epicardial fat pad thickness: 0.2, 1 millimeter, 1.5, and 2 millimeter. And we found that, actually, look at that. In this schematization, for example, if we use 0.2, everywhere there we will see epicardial fat pad in everywhere, and we should do very large ablation. But once we use 1 millimeter, and once we check correlation between this thickness and fragmented electrogram, we found that it was the best for our previous ablation expectation. So in the two case, we just check which one is the better, and then in the all other case, we prospectively use 1 millimeter for epicardial fat pad thickness to detect the localization of our ablation area. But in two arm, there was a little bit differentiation from in ablation point. Actually, in the first arm, we used our classical ablation approach. We tried to ablate all GP area: right superior, right inferior, posterior medial left GP, left superior GP. If we see any fragmentation on electrogram in Marshall tract or left inferior GP, we also ablated this side. But in CT arm, we just focused right superior GP or superior posterior septal GP, posterior medial left GP or inferior paraseptal GP, and left superior GP. Why? Because epicardial fat pad seems better in this localization. In Marshall tract or left inferior GP area, we don't see any epicardial fat pad. So we compared a little bit more larger ablation and more limited ablation in this study. So you see the steps of how we decide our ablation area. Look at that. This is the merge of CT and 3D map. And then you are seeing the localization of epicardial fat pad with 1 millimeter thickness. And then we ablated all this area. Again, our ablation endpoint was elimination of electrogram in any epicardial fat pad area. And also, if we see any positive vagal response, of course, we try to eliminate this vagal response as well. And of course, Josselin clearly explained that by using CT, we also see the localization of phrenic nerve and also sinoatrial nodal artery very well. According to my experience, I don't know the exact number of how many CNA I did, but maybe 1,000, I don't know. But I didn't see any problem with phrenic nerve so far. But of course, if we can not careful about that, we can ablate phrenic nerve as well, because in some patients, our ablation area is very, very close to the localization of phrenic nerve. So if you don't use CT, you should check the localization of phrenic nerve in all cases. And we compared both group. In all patients, there was still confirmed cardioinhibitor vasovagal syncope, very unique and clearly selected population. There was totally 44 patients in both group, 20 in the CT group and 24 in the EGM guided group, and we compared procedural parameters, autonomic effect, complication, clinical outcomes, prospective, of course, in quality of life parameters. You are seeing very similar baseline characteristics. And we see very similar vagal responses in left superior GP area in both group. But at the end, the total ablation point, of course, less in CT guided group, because we did very limited ablation in CT guided group, because we didn't perform any ablation in left inferior GP and Marshall tract GP. The syncope burden was similar in both group, just one in each group. Syncope recurrence, we also checked tilt testing in all cases after 1 month, and we just see one cases with positive positive bradycardic response during follow-up without any syncope recurrence. We just check routine tilt test results. But we also said that if we see any bradycardic response on follow-up tilt, this is a positive data for event. And also, we found lower ablation burden in CT-guided group, preserved sinus nodal effect, similar, but we found that actually CT-guided ablation is related more decrease on AH interval and delta PR interval. It was very surprising. So we, of course, in our cohort, we just focused to pure cardiointerruptive vasovagal syncope patients. So we don't have any AV block patient, but we found better AV nodal effect in this study by using CT guided strategy. So I think that more focused ablation is one of the advantage of CT, but I think that the most important advantage can be if we use clear anatomical definition like CT, it will decrease the interobserver variability and it will decrease the expertise level for importance of CNA results. As a take-home messages, inHEART makes patient-specific autonomic anatomy visible before ablation. It's one of the advantage. And also, if you clearly select epicardial fat pad thickness, you can detect the great majority of autonomic ganglia. And of course, larger randomized studies are required to say which is the best technique for GP mapping. Thanks for your attention.
That's amazing, Tolga. Thank you very much. Can I start with a question if that's okay? Tolga, you mentioned we don't always see the left inferior GP or the martial tract GP with CT scan. Or why is that the case? Why do you see the fractionation there? And classically, we target these areas, but we don't see these fat pads on CT.
I think that it depends on the thickness issue. If we use very lower cutoff for that, I think we can see something as well by using CT. But if we change, for example, if we use 0.2 and then we have to do too much ablation in everywhere. So according to my experience, actually, we see very less vagal response during left inferior GP ablation or even martial tract GP ablation. I think that in only AV block patients, martial tract GP can be important because sometimes I cannot achieve the desired endpoint by performing ablation around posteromedial left GP. In my order, in AV block cases, start with posteromedial left GP and then go to the martial tract GP and left inferior GP, just have one unit, and then turn to the right superior GP. This is my ablation order in AV block. This is totally different from classical vasovagal syncope patients.
So potentially CT can make you more specific in your ablation lesions.
Yeah.
One of the issues that I have seen is sometimes you find the nerve, the phrenic nerve, really close to the right superior pulmonary vein, and also the emerging of the sinus node artery. When it comes from the right coronary artery, it's really more anterior. When it emerges from the circumflex arteries, maybe pass through the posterior part on the right superior and in the septum, and it's really difficult to find this. You've seen in the tomography. These are really important information.
Sorry,
Tolga,
Juan,
talk to us about the use of the thickness of the artery to guide your ablation. Do you use it?
Yeah, I use it. So your point is very important. I actually said that we didn't see any complication with phrenic nerve, but of course we checked phrenic nerve in all cases. This is the reason. But sinus node artery damage, it's really difficult. You know, Juan, you did too many cases. So in some patients, for example, you increase the sinus rate very highly, very steeply, and then once in 1 second you see a steep decrease on sinus rate, and then you should stop. to do ablation. And I think that this is related to vasospasm on sinus artery. So we usually stop the ablation and then check a little bit far from this area to prevent such a complication. This is why we don't see any serious complication related to sinus node artery.
One thing we've been doing in our center is targeting the right-sided GPs from both the LA and the RA side because of the depth issue and all that. Is that your approach as well, Tolga?
Yes, in all cases, in CT arm as well.
Mhm. So, you know, a question that was going to come up more and more in the future, and is there any role for PFA with CNA ablation? What's the thoughts of both speakers regarding this? Or are we going to be doing RF for the foreseeable future?
Josselin, you have an option to use PFA. It's not available in Turkey, focal PF catheter. So let's start.
So there's very interesting data about that. First of all, you know one of the ways to assess how much denervation you're doing is by looking, of course, at heart rate, but also heart rate variability. And this is a measurement that's widely available. And the first thing you can point out is that compared to conventional PVI, so we have a lot of data on PVI, okay? And everybody saw that the right posterior GP is close to the pulmonary veins. So when you're doing PVI, at the same time, you're ablating these regions, okay? So using either radio frequency or even more so using cryo, you get very strong denervation. And so it's interesting to see, first of all, the difference between these two. We mentioned that the thermal conductivity is better in fat, so which is why actually cryo denervates even more than RF, okay? This is the first point. Second point is more specific to PFA. What we clearly see with PFA is that there is some stunning. So we did a specific study about this that shows that you get acute denervation immediately after PVI using PFA. So you can do that. You can check that basically when you do transjugular stimulation, you abolish or reduce the response after PVI. But from the heart rate data, we see that actually this damage recovers very fast. So the damage that we do on the DPs is not permanent at all. And in fact, PFA is much more specific than RF to working myocardium. So it's a very at least the current settings that we have for conventional ablation are really not well suited for denervation. So the first answer is using current tools, no, but just to point out one specific thing, there are also other tools being developed that are used mostly using an epicardial access, so direct epicardial access to the GPs. And these tools show potential promising results in a preclinical setting. So there are startups working on this, for example.
So I have no personal experience, but I evaluated two study. I think recently these studies will be published, some animal studies, and clearly show us that by using extracardiac vagal stimulation or some other parameters, animal studies, there is no effect on current PFA settings if you do endocardial ablation. Of course, Josselin is correct because if you do epicardial ablation and if you change your settings based on neural bodies, not for atrial myocardium, you can do selective ablation. But the question whether there we need to do epicardial ablation for CNA, for example, of course not. It's very invasive procedure for CNA because we have already ablated this GP by endocardial RF ablation.
We have one question. We have a question from the audience pertaining to how to perform phrenic mapping if you're doing general anesthesia. But in addition to this question, I want to ask your opinions on conscious sedation versus general anesthesia as a whole topic from both speakers, if that's okay.
Sure.
So for
I
me,
have,
yeah,
yeah,
okay,
go ahead,
Jose.
Tolga. Go ahead.
Okay, so for phrenic nerve, general anesthesia is not a big issue for us. We now use general anesthesia in almost all cases. So we can use phrenic nerve and we can see the phrenic capture very well. It's not a big issue. The second issue, which one is best? For example, I am doing sometimes workshop for new electrophysiologists to learn CNA. And of course, everyone wants to see huge vagal responses. So in that time, I use mild sedation or moderate sedation to see some magic. But of course, it's not needed.
Yeah. So you tend to do your cases offline general anesthesia? Yeah.
Exactly.
Mhm.
So I do only general anesthesia. That's because we do transjugular vagal stimulation. You get all the time you get sternocleidomastoid muscle capture because it's really just adjacent to the area that you're pacing. So it means that you get a very strong contraction of the muscles in the neck. And you can't do that, I mean, under local anesthesia. It would be really torture for the patients. It's too painful. So in that case, when you're doing transjugular vagal stimulation, which I already said I think is very important, then you need general anesthesia. That's imperative. You have to use it. And yeah, I agree with Tolga. There's no issue with the phrenic nerve. You should avoid using curars so that you can test the phrenic nerve. But of course, that's not an issue with GA.
Yes. Just tell your anesthetist not to paralyze completely, so
Exactly.
you can proceed with.
Yeah.
That's great. Some of the questions we get from people are number one, what is the long-term outcomes? And do you find that patients tend to have recurrences a year or two later? Because you guys both have a vast experience with a lot of patients. You've been doing this for years. And then the other question we sometimes get from general cardiologists are there any, do we ever see any adverse consequences long term? Because we are denervating what's a normal innervation in young people. Um, Other than the acute issues with phrenic and sinus dysfunction that are rare, do we see long-term negative effects in this population?
Those are two very difficult questions.
Yeah.
Very interesting questions, but very difficult questions. I can start and then Tolga can give his viewpoint. I think for recurrences, it's very hard to generalize in my experience. When I put the patients back on the table, so I systematically put them back on the table. So that's the first point. I mean, you could be tempted to potentially, switch to pacing, for example, when the patients have a recurrence. I always put them back on the table for two reasons. First of all, I think because I think that it's really better than pacing. That's the first reason. Second reason is because it's a really good opportunity to learn, you know. So and you do learn a lot in these patients, especially when you do vagal stimulation again. One thing I didn't mention too much, for example, is that vagal stimulation, so there is some selectivity in the innervation, so that we talked about this, meaning that the right internal jugular is going down into the posterior interatrial septum and then going to the left posterior medial GP. So for example, if you have re-innervation of the AV node and you get responses from the right side and not from the left side, which is a frequent finding on redos, then you should, increase your ablation, extend your ablation towards the interatrial septum rather than towards the left side. And the other way around, when you get a response from the left side, then you should extend to the left side and not the posterior aspect of the right interatrial septum. So stimulation helps also to guide your ablation, guide your redos, and unfortunately, there's like no magic recipe. Sometimes it's the same regions, it's just you didn't burn hard enough. And sometimes you have to extend to other GPs. But I find that the recurrence rate, even for redos, is never zero. But I find that I mean, this contrasts with what other authors have said. And I know, for example, that in the Czech Republic, they don't have this opinion. But in my opinion, redos are actually good. I have the same success rate as in first procedures.
Mhm.
I think that 5 or 6 years maybe a cutoff in future to do some redo cases because we see in very long term follow-up we see some reinnervation. For example, the patient is very well with 5 years, and then we see some bradycardia, and then of course some new syncope episodes, and we are doing redo procedure. But surprisingly, I realized a little bit change on the nerve area. For example, we see some antral location in some patients. because we found that the previous ablation point is very well. There is just scar in that area, but new fragmented electrograms in near site, in antral area. So we do ablation in this side and we increase sinus rate as again. The second issue, fortunately, it is not possible to do complete vagal denervation. We cannot do that. Fortunately, in animal studies, they can do. They see everything and then they can remove everything. But in human, it's not possible. And so why we don't see such a problem with sympathetic and parasympathetic imbalance. And of course, in brain innervation is another issue, a fortunate issue. And we see a little bit brain innervation, it will prevent any problem with that. And I have no serious problem with sympathetic overactivity in any patient so far.
I can comment all, yeah, I forgot to talk about the complication side. I think complications are they do exist. So long-term effects that we do see in my experience are twofold. So first of all, you get sinus tachycardia in these patients, and sometimes they're symptomatic because of that. The symptoms that they can get is either exercise intolerance or they can have shortness of breath. These are in my experience, the two main symptoms that you can get. And I think there is some sort of unavoidability of these symptoms. You have to be prepared for them potentially. And so what this means is that your indications should be good. You should not propose this type of procedure to any syncope after a first episode. You should really select the patients that have a favorable risk-benefit ratio for this procedure. And you should not take this procedure completely lightly. I think this is an important thing to say first of all. And the other complications that I have had is arrhythmia. This is much more exceptional, but you get, for example, AF in these patients. These are patients that have strong vagal, discharges most of the time. They have a higher propensity of having AF. And once you've done a little bit of ablation around the PV antras and you've not fully isolated them, then sometimes you have AF recurrences. I would say that this is under 5% of patients, but it does exist.
I had a patient actually where there was sinus tachycardia was an issue, and I put her on a touch of Avaberdeen, and she felt very well after that, and was happy that she's not having syncope anymore. So it was still worth doing the procedure for her.
Yeah.
Well, thanks to
Perfect.
both speakers. That was
Yes.
two great talks.
Thank you for participating.
Yes, so thank you to our presenters and guest panelists for your time and for sharing your experience with CNA. To all our attendees, thank you for joining us. And if you have any additional questions, please reach out at sales@inheartmedical.com. To watch videos from previous inHEART webinars, please visit inheartmedical.com, select resources and the webinars from the main menu on the top right of the screen. So thank you, everyone, and have a great day.
Thank you.
Thank
Bye.
you.
Thank you.